Welcome, everyone, to today's webinar, A Seat at the Table, Breakthrough Obstacles to Physician Engagement and Cost Savings. I am Brian Zimmerman with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Michael D. Brown is the Vice President of Managed Services at Cardinal Health. Mike's 30-year healthcare industry career includes helping hospitals and health systems meet strategic priorities by leveraging the pharmacy's impact across the organization. An expert on the many facets of cost control that the pharmacy represents, Michael also has extensive insight and expertise on drug utilization management and compliance monitoring. I would also like to introduce Dr. Heather Warhurst, Director of Drug Use Policy at Indiana University Health. In this role, she serves as System Pharmacy and Therapeutics Committee Co-Chair, System Pharmacy Representative on all clinical councils providing medication management strategies to decrease practice variation and reduce system drug spend. Finally, we also have Dr. Christopher Weaver. Dr. Weaver is the Senior Vice President of Clinical Effectiveness for Indiana University Health and a practicing emergency physician at Indiana's busiest emergency department. As Senior Vice President of Clinical Effectiveness, Dr. Weaver is responsible for quality pharmacy, supply chain, integrated care management, physician and advanced provider recruiting, and decreasing unwarranted clinical variation across one of the nation's largest not-for-profit health systems. At this time, I'm pleased to turn the floor over to Mike to begin today's presentation.
Thank you, Brian. The first thing I would like to do today is kind of go over the highlights of what our talk is going to be about. First, I want to give some kind of insights on how hospitals manage costs today, especially from their pharmacy department, and what they're really not doing to take them to that next step. Next, I'm going to pass it off to Dr. Christopher Weaver, where he's going to really talk about what they're doing at Indiana University Health to really take it to that next level, to get improve patient care and to control costs across the system. And then finally, we're going to hear from Dr. Heather Warhurst, and she's going to talk about the importance of using data to help tell the story and to drive change within their system. With that, it's been my experience that most hospitals, they really look at purchasing data when they're talking about pharmacy costs, and they develop programs around that data to really try to lower costs within the pharmacy department, but it's really pharmacy focused. Some of the things that examples of this are they work with negotiating their prices, whether through their GPO, their group purchasing organization, or they have individual contracts that they've struck themselves, but it's really trying to drive the price of that drug down. They usually operate very good P&T committees, so it's very formulary focused. That's what they want to have in their facility, that's what they want to use. And then the pharmacy itself performs the oversight to that formulary management. A lot of times I hear people refer to it, the pharmacy as really the drug police of the hospital, but it's all focused on that purchasing, really driving compliance to the formulary and monitoring it. These are all important. They're all best practice. Everyone should be doing these. However, this tends not to allow the hospital to take it to that next level that can generate sustainable savings. And to be successful in that, you really need to look beyond the pharmacy. You need to get all the stakeholders involved to really drive that change to affect that cost curve that you're seeing within your drug purchases, your drug utilization. And that's really pulling in best practices outside of the Department of Pharmacy to have that effect. To kind of illustrate this, there's really two areas that I think that you see that can do that, and this is what we're going to really talk about, and this is some of the things that Indiana University Health has been able to do. Most hospitals, like I said, they focus on price, and they equate price to the true cost of the drug. when price is basically, it's optimizing your GPO, it's getting the lowest cost in a drug, and it's pharmacy focused. Those are all important. However, true cost is price times utilization. So how are you using those drugs in your facility? And when you add in utilization factors such as how do I benchmark myself against other institutions on the use of my medications? How do I benchmark my physicians to each other within the institution? That becomes very powerful. They need to focus on disease state management of what you're trying to do with your medications. And then you have to have engagement from your stakeholders around that utilization. So how do you convince them to use the right medication? How do you convince them to use the medication in a certain way? But once you can multiply price times utilization to go after that true cost, then you will see sustained benefits of cost savings over time, and you'll also see improved outcomes. And as you hear today, you'll hear from Heather on how really focusing on that utilization data is driving those costs down. The second area that it is important from a pharmacy department is you really have to have the programs that can effectively drive change management within a facility. In the case of IU, they've always had inventory management, purchasing, and GPO optimization, waste recovery, typical pharmacy best practices. Those are important. I'm not saying don't focus on them. You still have to focus on them. However, they weren't hitting their goals and achieving what they wanted in their savings through their medication. So what they did is they were able to take that out of pharmacy and really drive it into the stakeholders. So they got physician involvement, they got administration involvement, and this took them to a new level where you have a care team focusing on your medication processes. They also leverage utilization data that helps them drive every decision they make within the facility, and they also use that data to help change the minds of the physicians and help them practice better when it comes to disease state management. When they put all this together, over the last 2 years, they were able to achieve cost savings of $24.7 million, which is significant, and they're continuing to see cost savings as they go forward. So with that, I would like to turn this over to Dr. Chris Weaver, and he's going to tell you a little bit about how the driving physician engagement in this process helped them be successful. Chris?
Thanks, Mike. Yeah, we're excited to be here today and to share, both Heather and I, and we've had a great partnership with Cardinal through this, and going to share how we've approached what we call unwarranted care variation. First of all, to tell you a little bit about IU Health. It's a large not-for-profit health system across the state of Indiana, 16 hospitals. We have a quaternary care academic level 1 trauma center in downtown Indianapolis, as well as a quaternary care pediatric referral center and trauma center in downtown Indy. And then we have 5 regions around the state of Indiana, each having a fairly large-sized community hospital as the hub, and out to critical access hospitals feeding into those. So pretty much the whole spectrum of hospitals across our place, with 4 large employed physician groups and partnerships with many private groups as well. And as we dug into how we wanted to drive, how we're all being forced to drive and want to drive and behind value over volume and the changes in healthcare, we really decided to do this and drive behind physician engagement and physician leadership. So the common phrase that's batting around the whole country these days, and all of us trying to figure out how to attack what we call unwarranted care variation. We reached into our physician leadership and stood up what we call clinical councils across our system. They are set up in a way where we ask our presidents and our CMOs of each region in our health system to nominate a provider in whatever specialty the council we're starting is, and most of them are specialty oriented. And we'll ask that president CMO to nominate an individual that is active in that practice, that whether they have an official position or title or not, that other people trust and follow. And from each region around our health system, we bring those individuals together to a table. Like I said, they're largely specialty oriented. We do have some that cross specialties, such as spine, for example. We have neurosurgeons and orthopedists together, or vascular council. We'll have vascular surgeons, IR, some cardiologists, and some general surgeons even, depending on who does what procedures across our system. And most of them are specifically within a specialty. So we get those nominations, we bring them together. We're very intentional to have equal representation across our whole system. And for the leaders of each council, which we call champions, to be scattered from around our system, depending on the council and the nominations that we get. In addition to those physician representatives, we have nursing leadership engaged as voting members in the council. And we have expertise from pharmacy, obviously what we'll be discussing today, as well as supply chain, IS, quality, and they come to each meeting both to bring opportunities to the table and to serve as experts and drive the conversation and help in the conversation. We have a great team of project managers and clinical data analysts it's critical to helping us organize the agendas and drive implementation of decisions that are made. And we'll talk more about the fact that data is king in this and how important it is to have some good data analytics and be able to drive behind that. As far as the scope of our councils, it pretty much covers about anything you could clinically. We try to focus, I mentioned the different representatives and experts we have at the table. We try to focus to make sure that we bring opportunities to the table in categories such as IS, so things like care pathways or order sets, supply chain, so driving good decisions across our system on the best evidence behind what the right device to use is, and in places where there's no such evidence, try to drive some uniformity to help us in our costs. Quality, driving behind variation that we see across the system and to external benchmarks. And then obviously pharmacy, as we're talking about today. And again, driving behind external benchmarks and variation in our system and really driving to improvements there. To share a little bit about some of the ways we have attacked things, to give you more specifics and to talk about some of the success we've had. We'll give you a couple of examples here. One, an area that all of us are dealing with, I know, and it's not unique to any one of us, and we're all fighting this battle, but the issue with narcotics across the country. And we have really worked hard to get good, clean data, comparing apples to apples, and within councils, drive behind that transparent data. And this is a great example of that. So in our emergency medicine council, for example, we chose the metric of % of patients discharged from the emergency department receiving an opiate. You can see on this figure that we were actually up at 11 or 12% when we originally started this. And really all we drove behind was being transparent with the data and gathering that information and showing in the council, and when I say transparent, I mean between people within the health system. I don't mean we put it on a billboard out on the interstate, but instead of putting doctors 1, 2, or 3, it says Dr. Smith, Jones, Weaver, and we share that openly. And we compare region to region how we're doing down to each provider. And the drive behind that is, and we share this freely and have open conversation of saying, look, the first time you see this, there's no criticism here. There's no statement of right or wrong. There's no, as a practicing ER doctor, I don't know what my peers next to me are doing as far as how often they're given an opiate or not. Until we get this data, you have no idea where you stand on the curve. And so when you first start seeing this, don't feel criticized or don't, be upset if you happen to be an outlier. The ask would be, if you are an outlier, start looking around at what your peers are doing, ask questions to those that are performing better in whatever metric that it is or differently than you. And you can adjust your practice pattern if, whatever the metric is suggests that you should. And then, leadership-wise, we have the conversations if 18 months to a year to 18 months into it, you're still upset that we're showing your data and you're an outlier, then, at some point you have to look in the mirror that, we've shared and worked through all the processes and helped you adjust things, and there's no reason to not share this transparently and drive discussions. Behind that, you see the success with opiates. We cut well less than half the amount of prescriptions of opiates across our place. We don't know the magic number is zero. We know that the drugs are the right thing for certain things, so it shouldn't be zero. Is the number is the percentage 4% or 6% or what? We don't know. We just know that you can be clear to say, if you're giving twice as much as everybody else, there's probably a reason or a possibility of looking at your practice. Another example of how the councils have worked to deal with discussions that I'm sure each of you deal with as well, the old IV acetaminophen discussion. At least for us, it's one that comes up frequently in many different ways from many different directions and just keeps coming back. And previously, we'd taken it to our Pharmacy and Therapeutics Committee, discussed the evidence, and taken it off the formulary. And that didn't stop the conversation from resurfacing every few months from multiple specialties. And really, the clinical council decision point and place to get decisions made has helped us a lot with driving peers to have these discussions. And what we drive to and ask for and expect is, if you're going to bring something, before something comes to the P&T committee, it needs to go through your clinical council with your peers. You have to be able to represent either how it improves quality of care with good evidence, good solid evidence, or how it drives costs down, or how it makes the life of a caregiver better, or some objective measure of how it improves things within the health system. If you can't do that and represent it at your council where you can get the support, then it's not going to come to the overall Pharmacy and Therapeutics Committee, and that's how we organize things and drive it. And there's been many examples of this with IV acetaminophen where the conversation has started, and with having that bar of discussion with the peers and the clinical councils, it never made it past there, so we didn't have to reopen the discussion at P&T. When you look at 2019, for example, so these councils are a little bit over 2 years old, say 2.5 years old here at IU Health. Our measures of success or goals for 2019 were, in the quality world, we aimed at mortality index and aiming toward moving us to the top performers in the country in our Vizient database for mortality index. And with each council, as you would expect, we have 30 councils going now, so between that many specialties, the work is very different in how you would drive to improve the mortality index or improve quality. But it's pretty easy to find an issue or a measure or something that you really need to improve on that would aim toward that, and that's how we've approached that for quality. Pharmacy world, what we've done each of the last 3 years is, when we look at inpatient costs per pharmacy index adjusted inpatient costs, we've said, okay, as pharmacy costs are going up and drug costs are going up around the country, we need to aim to be flat or better from previous year in our PIS adjusted costs. And so we've accomplished that each of the last 3 years, and as we've done that, we've beaten the goal and driven to a lower cost. And then for the next year, that becomes the new goal. And so from 2017 to 18, we outperformed it. Then that lower cost became the goal for 19, and we outperformed it. And then that lower cost is our goal for 20. Taking a similar approach for the finance metric for supplies and our CMI adjusted costs across our system. And then for engagement, this is really a surrogate measure and maybe not the best one, but we know for this kind of work, it's critical for us to have really significant engagement and participation across our physician representatives, both so we get good input to make good decisions and so that we can communicate and get buy-in behind this. So we've aimed at each year of having greater than 80% attendance across all specialties and all council meetings. And we have been above that mark each and every year and running at about 84% these days of participation at each and every council meeting. So really proud of that. We also do a survey at the end of the year to get feedback from them about things that went well, didn't go well, things we can do better. Our project managers, like I said, are incredible and do a great job with those things, and we get great feedback. And we've been really happy with that. And we hope over time that that's going to help us more and more with our overall physician engagement scores. And this is really the health system at its highest levels buying into physician leadership and engagement. And instead of me or any other administrator sitting in an office making decisions for them, it is saying, hey, come to the table. You're the right people, the experts, to make the decision. The caveat being you've got to make a decision. You can't just keep doing it the way you've always done it. The other promise we make to them is it's quality. So if we're able to see with our internal data or through published literature that one choice is a higher quality than the other, then that's the right choice, and that's what we're going to go with. In places where you don't have such evidence, then we've got to save some money and really drive value and drive quality up and cost down. And we're transparent about that and drive hard behind those conversations. As I say all that, and I'm excited about what we've done and how great things have gone, I'm not going to sit here and tease you or lie and act like it's easy. This is hard work. I'm sure all of you know you don't immediately get 10 physicians around the table that have been practicing for 10, 20, 30 years, and they don't run to the table and say, yippee, let's all do it the same way. They're used to doing things how they do it, and a huge majority have bought right in, but sometimes this is difficult discussions as you're trying to get people to change the way they do something and pick something together. So some high-level lessons learned, I guess we'll share. I'd say two things. One is data is king, like I said earlier. The more that you can get good, clean data to drive transparently behind, then the better off you are. We as caregivers will pick apart data with the best of them, and the more you can feel really good about it being apples to apples, the better off you are in those discussions. And then the other huge learning that we found was communications is really hard across healthcare, especially across a big, complicated health system. We grew fast, and not all of our regions to this point are organized exactly the same. And so when you're trying to reach docs, I mentioned earlier, from the 4 large physician groups that we have employed out to multiple private, not employed physicians, it can be hard. And you feel like you communicate 20 different ways, 20 different times, and still it's a guarantee that somebody's going to say it's the first they've heard of it. So I guess we want to emphasize the importance of that and really setting up multiple chains and ways to communicate and how often you communicate those decisions, both the decisions that are going to be made that we need weigh in on, and then the decisions that were made and getting it implemented is really key. And we think it's important to do it both from us getting a lot of communications out and really partnering closely with our leaders in each of our regions and our presidents, our CMOs, our quality leaders, our peri-op leaders, and our pharmacy leaders have been huge in this, and for them to actually be able to have the best chains of communication and drive and be accountable to drive this. Quickly, some things, we again, think this approach is great. It's worked awesome for us, and I know other places around the country have done similar sorts of things with collaboratives or councils or whatever the term may be. And we think it's the right way to go. We're really confident and love how it's come together. And a few things that we believe are really important if you start to think about a journey like this is really it's listed as a support group here, really your partners of obviously pharmacy, as we're talking about, supply chain, your IS team and your quality team, making sure all of those things, as well as some really good project management and hugely some good data analytics work, is put together before you get going. And those things really allow you to do the bulk of the work outside of pulling physicians out of their clinical time. And so you can have things teed up quickly so they're there to make decisions and you continue to drive things forward. Be persistent. Like I mentioned earlier, this work sometimes is not for the faint of heart. You can, if you're if somebody's really in love with a certain approach and you're trying to push through that because of the evidence, sometimes it takes persistence, repeated conversations from multiple places, multiple people, and so that's key. I mentioned transparency a few times, and I'm a big believer that that's, well, it's huge to leadership in general, and definitely through work like this, that we really have to be transparent with our goals, our intent, our data, our decision-making, everything, and that's critical. And as we talked about communications, when you're trying to be transparent like that and trying to drive culture change, which is what this is, the communications and trust that comes with good communications is huge. So with that, I want to turn it over to the real expert in this, and Heather Warhurst, who is our leader from pharmacy that drives all of this work. And I could sit here and talk and brag on her for the next 30 minutes and take up the rest of the time, but we'll let her tell you about the work she's done, and the partnership is critical in how we drive things. So Heather, take it from there.
Great, thank you, Chris. As mentioned, data is key. So what we provide and what we show providers is what's helping us tell that story and mobilizing for a clinical change. And just to show you how important that data is, I want to spend a few minutes just going over some of the examples of things that we've done to kind of show providers our information and our data to drive that change. As Dr. Weaver mentioned, pharmacy is one of the support groups for the clinical councils, and one of our goals is to keep our inpatient drug costs flat or lower than the previous year. So as we keep that in mind and we review recommendations with providers, we like to provide them with literature comparing the medications, but also if all things are equal in safety and quality, we do encourage them to use the least expensive item. And that's how we try and portray that story to them. We also encourage them to be innovative and support the providers if they want to study effects of comparative medications. For example, we're recently looking at Interreg as one of our high-cost medications and working with the general surgeons to study that compared to Movantik, which we also have on formulary, and to see if there is equivalent efficacy between the two, and then hopefully be able to drive using the lower cost item of Movantik versus Interreg. We've also encouraged the clinical councils and the leaders in those groups to challenge that, well, we've always done it that way thinking. We had a pharmacy restriction in place for large volume IV multivitamins, or some may know those as banana bags. And we had allowed a one-time dose to be given in our emergency room for patients at risk for encephalopathy caused by the rapid refeeding syndrome in severely malnourished patients. About a year ago, the OB providers had requested a similar exception to their patients as the ED providers had. And since there is no literature to support this recommendation at all, we took it back to the ED Council and the OB Council and asked them to really rethink this recommendation. Is this the best thing that we are doing for our patients? And those discussions ultimately led to us removing that option within our ED departments and allowing it in our OB triage departments. And now if IV multivitamins are given, they're just given as a piggyback, as a one-time dose versus in a large volume bag as we had in the past. Just to kind of also share some of our experiences, I wanted to briefly mention how our system P&T committee works and how it provides clear lines of authority on our decision making in our very large health system. So all the way as early as 2008, IU Health had some sort of system pharmacy and therapeutics committee. As our system has grown, so has our processes, and we've really tried to refine that the way we look at medications and add things to formulary. So to briefly describe our process, as Dr. Weaver mentioned, if a provider wants to add something to formulary, they will work with their local leadership, usually the CMO, to get approval for moving forward through the process after gathering all of the literature. If we've had any non-formulary usage within our system, we gather all of that data and then share it at the clinical councils with those experts to help make and drive what that recommendation would be. Each of our regions has a formal formulary review process in place, so that would be the next step for review. All of those recommendations then go to our System, Pharmacy, and Therapeutics Committee. That system group has representation from each hospital. They have one pharmacist, one physician, and one nurse, and collectively they cast one vote for their hospital in either to approve or deny the proposal that's at the table. Since there is only one physician, they may not be a specialist in the area of what we're discussing. It sometimes had led to, oh, well, we'll just add that to formulary and then we'll watch it. We'll see how it goes. The clinical councils have been able to help refine that feedback and get that specialist data to the P&T members to be able to help really guide those decisions. So next I would like to discuss a couple of examples of reviewing high-cost medications, some of the things we've taken through our system P&T, and then how we implement and drive for accountability for our initiatives. So when the councils first developed, the big question was, how do we identify what we should take to the councils? We would meet with council leaders or pharmacy specialists in those areas and kind of see what ideas they had. We shared with them what our high-cost medications were that focused in their groups, and then used those to generate ideas of data that we would want to take to each group. We also looked at benchmarking tools that Cardinal provides to compare ourselves to other institutions and looking at where we compare in that high drug spend. So kind of giving a couple examples under the high-cost medications first. As I mentioned, we do use benchmarking tools to identify ourselves with peers, but we also use them within our institutions. So one example from where we had a best practice within our system was IV calcitonin. Calcitonin, which is a treatment for malignant hypercalcemia, increased in price from about $65 a vial to a little over $3,000 a vial in 2018. There's evidence to show that the hypocalcemic effects of calcitonin diminishes after 24 to 48 hours. However, we would allow continued use of this product throughout our system past that time frame. One of the hospitals implemented a 48-hour stop date on all IV and sub-Q orders and showed a savings of approximately $200,000. We took this best practice to our Medical Oncology Council to propose a similar restriction across the system and then ended up saving an additional $537,000 over the next year. Now that's an example of just what one council could do. There are several high-cost medications that kind of go across several of our councils that we have to get feedback from various disciplines. Exparel, or liposomal bupivacaine, is one of those. So as I started my journey in storytelling of Exparel, I started with the total joint orthopedic group because that is one of the areas where there is published literature for the treatment, for surgeries in the use of Exparel in that use. However, our surgeons had recently studied liposomal bupivacaine, the standard bupivacaine, and found no difference in outcomes, so they made the stance that they did not need to use Exparel in these procedures. We received
It looks like Dr. Warhurst just got kicked off, so she's actually noted that she is signing back in, and we will resume the presentation in just a moment. Thanks so much, everyone.
Hi, I apologize for that loss of audio. Can everyone hear me okay?
Yes, thank you so much. Continue on.
Great. Thank you. I believe I was talking about XBRL. So the guidelines, after we received that feedback from neurosurgery, we shared it with our general surgeons and anesthesiologists, and they believed and had literature to support that there were some patient populations that may still be able to benefit from the use of liposomal bupivacaine compared to standard bupivacaine. And these restrictions were then taken to System Pharmacy and Therapeutics Committee and were implemented across our system. We've also been able to leverage the councils to serve as a liaison for P&T feedback. In some examples of those, during our annual pharmacy inventory, we noticed we were expiring a lot of our IV allopurinol, so discussed formulary removal of it with our Medical Oncology Council. This resulted in a savings of $168,000. As identified through our XBRL example and some other high-cost medications, we really thought it was best as we review some newer therapies coming to market that we develop practice guidelines during the approval process rather than after it's been on the market for quite some time and then everyone just started using it and became in love with it because it was the next best thing. So when angiotensin II came to the market and we had discussions with our critical care council, we went ahead and devised the appropriate patient population and parameters that must be met prior to starting the drug and continuing the drug, and then deciding also when to wean it off. After the approval, we then provided the council back with quarterly data just to kind of continue to show how they were using angiotensin II, if the patients were meeting the guidelines, and what other outcomes were occurring with that. So I wanted to make sure that the council was provided with continuous feedback in how they were doing in regards to their ordering. The next example is how we kept a medication off formulary, and that would be Indexa. As I mentioned in our P&T structure and subcommittee, not all providers that sit on our system P&T are experts. And so when it came to Indexa, I wanted to make sure that I had taken it to several councils to get that feedback in regards to if it was something we wanted to pursue adding to formulary or not. The clinical councils reviewed all of the published literature to date, discussed all the advantages and disadvantages, and decided that there was some concerns in regards to increased rates of thrombotic events, so decided not to add Indexa to formulary and sent that recommendation to the P&T committee. The last example, which I'm sure is very prominent in most people's minds, is biosimilars and how are we handling biosimilars. We took our biosimilar discussion to our Medical Oncology Council, and the medical oncologist had decided and discussed if the FDA approves the biosimilar equivalent to the parent compound, then we will have the same stance and we will use whatever the cheapest agent is that we can get. Now, ideally, that is the biosimilar in most cases. So that has really helped streamline our P&T process where we don't have to take each of those new biosimilars back to the clinical council and then through the P&T process, and we can just take it straight through the P&T process as a purchase restriction on which agents we will be using. Now, for the most part, the storytelling and getting the approval from the clinical councils has been pretty easy. I mean, there are some road bumps, of course, and there's some discussion and some delays, but for the most part, everybody buys into the recommendations and decreasing variation and wanting to standardize how we treat our patients. The implementation is definitely been a little bit more difficult. If it's something that we take through P&T, we have that process standardized. Our communications are standardized, our builds in Cerner, and then how we communicate to pharmacy and physicians is streamlined. However, there are some initiatives that just don't need that P&T approval or restrictions put into place, so the physicians kind of own that accountability and communication to their peers at their local regions. Now, I did want to share one that the physicians owned and have done a wonderful job with in driving the change is Sugamidex. So as most of you know, Sugamidex and neostigmine, when Sugamidex came to the market, they were about equivalent in price. Over the years, the neostigmine glyco combination has dropped significantly in price and is now about $60 less than Sugamidex. We did a medication use evaluation looking at Sugamidex and the types of patients that it was being given to post-surgery. We shared that information with the anesthesiologist along with our current spend, which was around $1.8 million in 2018, and asked, are all of these patients appropriate? Can we think broader and use neoglyco for patients that probably don't require as quick reversal as what Sugamidex will provide? They took ownership of this initiative, started having conversations with their peers, determined appropriate patient selection, and then even some of the sites decided to remove it out of their anesthesia trays so it would not be readily available for use. Knowing that it took some time to change behavior, we provided those lead anesthesiologists with monthly reports showing them the usage of their Sugamidex and their neoglyco, their monthly cost savings compared to their previous months, and also their peers across the system. And as you can see from this graph, that we have saved almost $650,000 over the past year, and for most months sustained around a $60,000 cost savings each month. IU Health also has been known for its robust, customized electronic medical record. Even though we've had a closed formulary, we displayed most of our medications in our physician order entry catalog, including our non-formulary medications. Most pharmacies had a supply of frequent non-formulary medications on hand. In the fall of 2018, we decided to remove all non-formulary drugs from the catalog, and if the provider wanted to use something that was not on formulary, all they had to do was fill out a form and describe how this agent was more beneficial or was needed over a current formulary agent. As you can see from this graph, after we removed non-formularies, our extra orders decreased to less than 400 orders over 5 months, and we still continue to see low use of our non-formulary items. So I've given lots of examples of some of the pharmacy initiatives that we've had through the clinical councils, but I really want to say that this all would not be possible without the data. And the data has really been very pertinent to our storytelling. Of course, I do use evidence-based literature where I can, and comparing the medication classes, showing them our budgetary impact, but I also like to show them utilization data. And having real-time data helps with the variation across our system. The clinical effectiveness team also has a great team of data analysts that work closely with the providers ahead of the meetings to align on which data to highlight, eliminating any outliers or any other data that might be needed to incorporate so that we can anticipate any questions that are going to be asked during the meetings that we have. To get the best results, when you can show how IU Health compares to other systems, you really have to make sure you're using like systems. It is important that we have minimal variation, and when we don't have another specialty within our system, such as transplant, that we're able to compare to these outside hospitals. When we benchmark ourselves against hospitals that perform similar procedures, both types as numbers, we also look at their CMI, so looking at the types of procedures that they provide, the types of patients that they treat, and the numbers of those procedures as well. We focus on what we are doing well, but then also more importantly share with our providers where there's variation and where we can improve. As I mentioned earlier, we compare our hospitals to each other within our system, but we also break down by hospital and provider. As Dr. Weaver mentioned, the ED encounters with narcotic prescriptions, it was very helpful to be able to show the providers that data and how they compare to their peers. Since each council focuses on a specialty, sometimes the data may have to be broken down by a patient population or a DRG, so I can share that information with multiple councils. For example, the XBRL, it was shared with multiple different sites. We also have gotten as granular as doses. For example, with the OB Council, they had decided to not give dinoprostone to patients greater than 2 doses. And so I would share on a quarterly basis the number of doses that they were prescribing for patients so they could continue to drive that change. After we decide what data to share and who to benchmark against, we have to make sure that we can trust the data we are providing if we want to be able to drive this change. I will spot check a lot of the data before I provide it to the providers to make sure that I have correct data and that there's no errors, because that can quickly cast doubts into the findings. It also can lead to questions that they have if the data is not correct, which then pushes us back a whole nother quarter to be able to implement changes and see some of that savings. Another question that they sometimes ask, are my patients sicker? As mentioned on the previous slide, we compare to our peers. We have to ensure we're comparing like hospitals with similar comorbidities and diagnoses. As Mike mentioned at the beginning of this presentation, pharmacy, we've saved over $24 million, but specifically to some of these pharmacy initiatives within the clinical councils, we've seen an $8 million savings over the past couple of years, which has all been great and very contributed to showing accurate data. I want to thank you for your time, and I'll turn it back over to Mike.
Thank you, Heather. And I appreciate both you and Chris going over some of the successes that you've had within the IU system. I think it's proof that when you involve everyone from the care team in the medication management program and you use data really to help drive your decisions, that you will see sustained change, you will see improved quality, and you'll see your costs go down. So like I said, once again, congratulations on your success. Now, I know the two of you have been doing this since I think 17, so a couple of years now. My natural question is, before we open it up to a broader question, is what's next for you? What's next for your teams?
So, Mike, this is Chris. I'll say overall more of the same. This is culture change for people in medicine, I would say in general, coming together and making these decisions and sticking to those and not individualizing it too much. So more of the same in that. We have some specific initiatives pharmacy-wise that Heather can tell more details about, but having to do with biosimilars, with the opportunities coming forward with those, levothyroxine and some other specific ones that can be discussed. But really just more of the same kind of work and driving behind this engagement and transparency of our data and information.
Yes, I would
Heather,
echo
do you want to
that.
add anything, or do you want to just go? Oh, go ahead, Heather. Go ahead.
No, I was just going to say I would echo all of those comments that Dr. Weaver made.
Okay, great. Brian, I'm going to turn this back over to you to see if anyone has questions on the phone.
Excellent. Thank you, Mike. And thank you, Dr. Warhurst and Dr. Weaver, for that insightful presentation. We will now begin today's question and answer session. So please submit any questions you have by typing them into the Q&A box you see on your dashboard. And we'll try to get through as many questions as we can. We've had a bunch of great engagements so far. And the first question we'll take here is, how do you approach doctors who may disagree with clinical counsel decisions?
I know it's shocking to you all, but that happens. And that gets to some of the point I made about it not being for the faint of heart. But the way we try to approach those first, we will try to encourage those conversations as much as possible during the decision-making process and with their peers and in the council setting so that you can really drive behind the evidence. In times where that does not happen and a decision comes out and we're implementing and they disagree, then typically we will engage best we can the leader of that council, since in the same specialty, in that conversation with them. And then I will help participate and have that conversation, again, drive behind the evidence, the accountability. And if there's times where, as we're tracking the data, they're still not buying in and complying and participating, and that's where one of the reasons we built our teams the way we did, that's where we'll engage with the president CMO of that facility, that region, and really have the conversation on that of all of us talking about it together and driving the improvement together. And it's really their, if it's a dollar thing, it's their bottom line, their budget that it's affecting. And so that local leadership helps a lot in that conversation and driving the true implementation. So we think that's really important. And the more they're engaged up front and deciding who's on that council, the easier it is to partner in that conversation on the back end.
Excellent.
I guess I could add in the pharmacy world, obviously the easier ones are the things where we say, the evidence does not support this medication at all and you can take it off formulary. That's pretty easy to implement. The tougher ones are, Sugamidex, for example, when it's a great drug. And we admit that, acknowledge that, all of us support the use of the drug in the right situation. And we're really just trying to drive the accountability of, you've practiced anesthesia for 100 years without using it on every patient. So can we target it to the right things? And those are harder, more nuanced conversations that having that local leadership engaged is really important.
Yeah, it sounds like having the local leadership and just really being straightforward and transparent about the goals, right?
Yes, sir.
Excellent. And so the next question we'll take here is, this attendee asks, what recommendations do you have for applying drug utilization data?
So like I mentioned throughout my presentation, it definitely is important to have that utilization and information that you share with the physicians on how they're doing and how they're prescribing, not only before changes are made, but then also during the whole process. We try and share feedback with them up to a year after that change is made, just to kind of help hardwire that change and show accountability on how they're doing against their peers across the system.
Great, appreciate that. And so the next question I have here is touches on opioid utilization. So the attendee asked, did you provide the ED physician opioid utilization unblinded right out of the gate, or did you start with blinded data initially?
And that one we started unblinded right out of the gate. And we encourage and are driving behind that across the board. And I think when you look at quality performance and places that have gone from mediocre performance to a top performer, it's pretty clear that's one of the best ways to do it. And I think that's true behind all this. And, like I said, we're not pointing fingers in it. It's really just to drive conversation and transparency. So that's the way we've done it 90 8% of the time. We've had a couple of specialties that are really, that's really big culture change for, that they've really been uncomfortable with that we may have started the first, few conversations with blinded, gained some trust and comfort and evolved. But we really try hard to drive behind just being transparent from the get-go.
Yeah, the theme of transparency is definitely prevalent in this conversation, but also appreciate that flexible enough to take a nuanced approach when necessary, or a different approach. And so the next question I have here is, did you experience any difference in adoption from academic clinicians compared to community providers?
So it depends. Yes, but not always in the direction you would predict. But they see things differently sometimes, and that's one reason we've driven really hard behind including the entire system, because really it's important to value the input of the different perspectives, because most of the time it's from reasonable angles and for good input. So we do see differences between those, but I will say again, the huge majority of the time they come together pretty quickly, where there's any evidence at all. There are a lot of things we do don't have clear evidence, and that can be harder sometimes. But Heather can chime in, but I would say the huge majority of the time the academic versus community has not been a big deal. Sometimes there were a couple councils we had to encourage everybody to speak up. Maybe some were a little bit less comfortable than others, but it's gone really well. Heather, take on that?
No, I would agree with what you said 100%. And I would say that the academic physicians have been really good lately in kind of saying, well, we don't have any literature in that. I want to be able to use it, so I'm going to trial it out on my patients and see how it works. So taking that step approach to that versus just hard saying, nope, NREG, for example. Literature supports NREG. It's the only FDA approved for post-op ileus. That's all we're using, and really starting to think outside the box.
Excellent. Thank you both for those perspectives there. And so the next question I have here has to do with, I believe, physician incentives. So the question is, what measures have you taken to increase physician involvement? OPPE credit, MOC credit? So
I will say physician incentives, the whole conversation we have often. We had, I was to say some, but I think a small pocket where when we started doing this work, that because of the federal programs, you had some shelter and it's easier to make some incentive things, and bundled care for total joints, for example, some small financial incentive piece in there of sharing. We quickly decided it's this leadership. This is a really true leadership test, and that we try not to do as much as we try to do as minimal of that as we have to. So we've gone away from that as far as financial incentives for each project. Now, I think it is the right thing that we're all on this team together. If one party's doing well, then everybody should do well kind of approach. But we're trying to stay away from the individual financial incentive piece of it. We are able to partner with them, like you said, for the FPPE stuff and the quality programs that they want to participate in and stuff like that, which is incentive for them and their team members. And we've tried to stay for overarching approaches like that instead of a dollar incentive approach to anything. The rules make that tricky, and it's just, it's shown that once people make a certain amount, that doesn't really move the needle anyway. So people bring it up frequently. So
great, definitely appreciate you taking that one. And we're at the end of the hour here, so I want to invite any of our presenters to share any final thoughts they might have.
This is Chris. I'll just say thank you all. Great conversation, and thanks for the partnership and the learnings from Beckers and Cardinal, and always to Heather. So nothing else from me.
Yes, I second all of those thank yous.
And I'd like to thank both Chris and Heather for participating in this. I think there's a lot of good information shared with the people on the line. Thank you.
And that is all the time we have for today. So I want to thank Mike Brown, Dr. Warhurst, and Dr. Weaver for their excellent presentation, and of course Cardinal Health for sponsoring today's webinar. Everyone enjoy the rest of your day, and we look forward to having you join us for future webinars.